Dr. Rada.
Good morning, everybody. How are you all? Thank you all for being here. We have a wonderful panel this morning. And I would like for Terrell to introduce the rest of the speakers. Or Lauren, were you going to do it?
No, I believe Ken is actually introducing the speakers.
Okay. I think it'd be best if everyone introduces themselves. Lauren.
Sure. Hi, everyone. My name is Lauren O'Connor. I currently work as a biostatistician for the DC cohort here at George Washington, and I'm also pursuing my PhD in epidemiology.
Awesome. Thank you so much, Lauren, for being here. Terrell.
Hello, everyone. My name is Terrell Parker. I manage the Escalate program at IMAC, which stands for Ending Stigma Through Collaboration and Lifting All to Empowerment. Thank you for having me. I'm excited to be here.
Welcome, Terrell. Ken, good morning.
Good morning, everyone. I am Ken Pettigrew. I'm the Director of Capacity Building at Help HIV in the District of Columbia.
Kristen. Good morning.
Good morning. Hi, everyone. My name is Kristen Kasilik. I'm an assistant professor of mental health law and policy at the University of South Florida in Tampa, Florida.
Well, good morning, everybody. I think it'd be wonderful if each one of you take a few minutes to give a narrative before we start the discussion in your own area. Kristen, would you like to start?
Sure. You just want me to say a little bit about my work?
Your work, yes.
Okay. At USF, I direct a research lab called the Stigma Action Research Lab, or STAR Lab. So all of the research that we do in STAR Lab aims to understand and address the stigma largely surrounding mental illness, though I have been doing work more now in the area of HIV. So today I'll talk a little bit about one of the federally funded grants that we are working on right now, aimed at addressing internalized stigma among college students in order to help them to persist towards graduation.
Awesome. Ken?
Again, good morning. Today, I simply serve as a moderator to hear from other folks around what they're doing in their areas. Currently at Help HIV, we work a lot with community-based organizations around stigma. It is really important, as was said earlier, so it is important for organizations to address, hoping to hear tools that organizations can use to address stigma and throughout the country.
Ken, my apologies. Take it away. You are the boss.
No, I'm nobody's boss, and I don't mind.
No, but
I'm a being a co-pilot or a background singer.
For a second, you know, I'd lost the briefing that you will be the moderator, and I was just to introduce you. Yes.
You are totally fine. I do think there are a couple of other introductions left as part of the panelist. We heard from Lauren, we heard from Kristen. We do hear from our folks, Elle and Duncan. Are they on the call? Not sure if they're on the call yet, but what we can do is go ahead in terms of the presentations that are available. Let's just do a little popcorn here. Let's have a little fun. Lauren, you want to start us off with your presentation? You knew I was coming to you, didn't you?
Sure, certainly. I can start us off. Okay. So hi, everyone. My name is Lauren O'Connor. As I said earlier, I work as a biostatistician with the DC cohort, and I'm looking forward to talking with everyone today about patient-reported mental health and stigma among people with HIV. So for our study, we had two main objectives. The first one was to evaluate stigma among participants in the DC cohort and to determine which factors might be associated with stigma. For those of you who may not be familiar, here's some background on DC cohort. We are a longitudinal database on HIV clinic outpatients in the DC area. As of right now, we have about 11,800 participants across 14 different sites, making us one of the largest HIV cohorts to date. And we collect data on risk factors, diagnoses, lab results, treatments, almost anything you could think of in the electronic health record, with our ultimate goal of improving quality of care, providing evidence for gaps in care, and identifying areas for future research in the HIV space. And within DC cohort, we will occasionally conduct sub-studies and ask a subset of participants to take part in them. The one I'll be focusing on today is our patient-reported outcomes sub-study. And this is a self-reported survey on patient-reported outcomes, or PROs, among DC cohort participants. Participants, when they go in for their regular to meet with their regular HIV care provider, they will answer questions on quality of life, symptom burden, mental health, adherence to their ARVs. And then what I'll be focusing on today is they also answer questions about stigma. And as of September 1st, we had over 700 of our participants complete our PROS survey, and those will be the surveys that we're focusing on today. And ultimately, our goal is to have participants complete these PROS surveys annually so we can get longitudinal data. We haven't gotten to that point yet. The survey just started last year, so this is the first wave of it. Okay. So as I mentioned, in this PROS survey, participants answer a long list of questions, some of which pertain to stigma. Specifically, our survey presents 4 statements to the participants that was adopted from Earnshaw originally in 2013. These 4 statements are: having HIV makes me feel like I'm a bad person. Having HIV is disgusting to me. I feel ashamed of having HIV. Or I think less of myself because I have HIV. Participants read each of these items and then respond on a Likert scale, anywhere from strongly disagree to strongly agree, and their response gets a number assigned to it. We then take the average of all of their responses and calculate the individual's overall stigma score. And this stigma score is what we'll be focusing on today, where higher scores refer to higher levels of stigma. Okay, here's an overview of the participants who have taken our PROS survey so far. Average age is 54, mostly male, mostly non-Hispanic Black. And then some of their HIV risk factors. We have the most common risk factor was men who have sex with men, followed by high risk heterosexual. Mostly our participants have viral suppression, and about 2/3 of them reported perfect adherence to their ARVs in the past 2 weeks. Okay, so as a reminder, our first objective today was to evaluate stigma among participants in the DC cohort. These are the 4 items that were given to them in the survey. And the first item, having HIV makes me feel like I am a bad person. This was definitely skewed towards strongly disagree, with just under 60% saying they strongly disagreed with that statement. A similar trend was shown with having HIV is disgusting to me, a little bit lower, but again, anywhere from 50 to 60% strongly disagreed with this statement. However, the statement, I feel ashamed of having HIV, did have a high level of agreement to it. Just over 40% said they strongly disagreed, but just over 40% also said they agreed or strongly agreed. So this statement was definitely the statement the most people agreed to. And then I think less of myself because I have HIV followed similar trends to the first 2. And when we look at everyone's overall stigma score, it definitely was skewed towards the lower end. That lines up with the usually saying strongly disagree to each of the 4 items. But we did have an average of 2.1, and that would correspond to, on average, participants saying they disagree with the statements. Okay, so our second objective was to determine which factors are associated with stigma. First, we looked at a bunch of crude associations using linear regression, and I know this is a really busy table, so instead I'll draw your attention to the more interesting findings. First, we found that age is inversely associated with stigma. People who were older tended to score lower on the stigma score. Similarly, time since HIV diagnosis, the longer time that had passed since their original diagnosis date, the lower they tended to score on stigma. With depression, we saw the opposite score. The higher they scored on our depression scale, the higher they tended to score on the stigma scale. And a similar trend was found with generalized anxiety disorder. So let's take a closer look at some of these trends. First, as I mentioned, we found that older individuals on average tended to score lower on the stigma scale. In fact, a 10-year increase in age was associated with a 0.18 decrease in stigma score. However, what was interesting about this finding is we found that this association really depends on your gender identity. This graph here, I'll pull up a laser pointer. This graph here is split up by gender identity. So first, this yellow line is referring to individuals who identified as female. Among them, age was associated with a 0.32 decrease in stigma score. And you can see this slope here. As individuals age who are female, stigma tends to go down. However, if you look at male, for example, which is this blue line here, the decrease is much less severe. In fact, among males, it was only about a 0.14 decrease in stigma score. So among males, the effect of age is not as severe as among females. Then, if you look at this gray line here, this was individuals identifying as transgender. And for them, there was a 0.48 decrease for every 10-year increase in age. So among females and individuals identifying as transgender, age is having a pretty substantial impact on stigma experience. As individuals age, stigma tends to go down. However, this trend was not seen to be as strong among individuals identifying as male. Okay. Similarly, we did find that the longer time that had passed since their HIV diagnosis, individuals tended to score lower on the stigma scale. In particular, a 10-year increase in time since diagnosis is associated with a 0.26 decrease in stigma score. The opposite trend was shown with depression. The higher individuals scored on our depression scale, the higher they tended to score on the stigma scale. And to put things in perspective, individuals who scored above 10 on this particular scale would have been considered to have depression. And then similarly, we found with generalized anxiety that the higher individuals scored on the scale, the higher they scored on the depression score. However, this trend tended to plateau. Specifically, it plateaued around moderate to severe anxiety. So there is an increase in stigma for mild anxiety, for moderate anxiety, but once you get to severe anxiety, there really is no difference between moderate and severe. So that was an interesting finding. Okay, finally, we wanted to take a look at just developing an overall model to find associations with stigma and better understand what might be contributing to this increase in stigma score. We looked at a bunch of different covariates and we ran various simple linear regression models just to see how each of the covariates were associated with each other, looked at some fit statistics, and ultimately developed a final multiple variable linear regression model to better understand how factors are associated with stigma. And I'd like to point out the model I'm about to present has two limitations. Stigma score was not normally distributed, and depression and generalized anxiety did exhibit signs of multiple collinearity. So overall, our final model included generalized anxiety disorder, and we included a term to account for the fact that it plateaus, age, depression, gender identity, and years since HIV diagnosis. We also included an interaction term between age and gender to make up for the fact that the effective age did differ by gender. And here is the overall adjusted associations between stigma and each of our covariates. Again, this is a very busy table, so instead I'll talk about what does this table mean. Well, first, let's take a hypothetical participant. Let's say this participant was 22, identifies as female, has no generalized anxiety disorder, no depression, and it's been 10 years since their HIV diagnosis. On the stigma score here, on average, they might score around a 2.76. However, let's take someone with these exact same characteristics. Instead, they're 42. On average, this individual might score around a 2.37. So the increase in age is leading to a decrease in stigma score. However, remember that I said that really differs by the individual's gender. So let's say instead this person is male. We take a 22-year-old male, on average, they might score around a 2.08. However, if this individual was 42, they're really only scoring barely any higher than they were before. So among males in our model, age is not really having a major effect. Okay, this individual is 67, identifies as transgender, has mild anxiety, and is just under the cutoff for having depression. It has been 2 years since their HIV diagnosis, and on average, they might score around a 1.93. However, if we take someone with these exact same characteristics, except it's been 32 years since their HIV diagnosis, they score around a 1.34. So that increase in time since diagnosis is being associated with a substantial decrease in stigma score. Okay, finally, our last individual is 24, male, and it's been 1 year since their HIV diagnosis. Let's say that they have no generalized anxiety disorder and no depression. They on average would score around a 2.21. However, if instead we found that they had severe anxiety and they had depression, their stigma score increases to a 3.15. So this is a pretty big jump just in the presence of having mental health issues. And so mental health is really contributing, poor mental health is really contributing to increase in stigma score. Okay, so that was a lot of information. So a quick summary of what we went over. The most participants agreed with, I feel ashamed of having HIV than any other statement. On average, stigma score is moderately low, on average, referring to participants saying they disagree to items. Older age is associated with a decrease in stigma score, but this trend is much stronger among individuals who are female or transgender. The longer time that has passed since HIV diagnosis, the lower individuals were scoring on the stigma scale. Generalized anxiety was associated with an increase in stigma, but this trend tends to plateau. And overall depression is associated with an increase in stigma. And what does this mean? Well, first, again, we evaluated stigma among participants in the DC cohort and found that levels are moderately low, but feeling ashamed of having HIV seems to be driving stigma. Age, years since HIV diagnosis, depression, and anxiety are all associated with stigma. So with that, in the future, as I mentioned earlier, we are planning on giving this PROS survey out once a year. So I'm definitely interested in examining longitudinal data on stigma. And with the factors we found to be associated, we're also interested in eventually looking at retention and care, substance use, and other HIV outcomes to determine how that might be associated with stigma. In the long term, we could look at stigma using this stigma scale as a measure of identifying patients with mental health needs. The two were very much associated. And this is much easier said than done, but better understanding the causal relationships of stigma so then we can work to reduce it. I'd like to thank all of my co-authors on this project, my colleagues at the Department of Epidemiology, the George Washington Biosat Center, and the Health Department, as well as all of our incredible DC cohort sites who work so hard to get us this data. I'd like to thank the National Institutes of Allergy and Infectious Disease for supporting DC cohort. And as always, a huge thank you to all of our DC cohort participants. This pro survey had over 400 variables involved in it. So it took a very long time for them to fill out, and I appreciate them giving us this data so we can better understand stigma. And thank you for your time. I think we're doing the Q&A at the end, but when that is, I'll be happy to take questions then.
Yeah, thank you, Lauren, for a great presentation. We will do Q&A at the end. It was surprising. I saw a couple of things that we can talk about, but there was just one thing that you thought stuck out in this that you found surprising.
Yeah, so one thing that I found really surprising was that age based on the individual's gender. I wasn't expecting that. I don't really have a good explanation as why that might be happening, but I found that really interesting, the contrast between the effects of age. I mean, it was almost non-existent in males and had a really big effect in female and the transgender population.
Thank you, Lauren. We'll definitely come back to that because I found that interesting as well too. Next, I'm going to go to Kristen and just introduce yourself again for people who are joining us, and we'll begin with your presentation.
Sure. Thank you, Lauren. That was a fabulous presentation. I really enjoyed it and hope we can connect. Let me see if I can share my screen. Here we go. Let's try this. Sorry, give me 1 second. I'm on a new laptop and it's asking me to allow this to share. So it's saying that I have to quit and reopen Zoom in order to share my screen. Are you okay with me doing that?
Ken, is it okay to ask a question from Lauren in the meantime?
Sure, I'll be right back.
Lauren, thank you so much. That was so awesome, so wonderful. You know, again, I deal with a very different population. I take care of primarily children who were born with HIV, and I have taken care of them. You know, Patty is here too, and we've together taken care of these people sometime for 20, 30 years. And I've taken care of their mothers in a limited sense. So what I find difficult is that, for example, we didn't ask about disclosure. I know it's a very tricky question. In the surveys, we didn't ask, and disclosure in different spaces. So, and also, you know, when people are filling these surveys, they are in one space, which is probably the least stigmatizing of all spaces because they feel free to talk about it openly. Whether when asked the same question in another space, whether they would answer the same way, I don't know, I'm not sure. Because people I know with HIV, that includes mothers and children, they, you know, their disclosure has not changed over 20 years. Many of them are permanently scarred, and they may answer one way or the other on stigma, but when you look at their life, when it comes to disclosure or, you know, feeling comfortable having a relationship, feeling guilty and shamed about not having disclosed to many, that remains. But thank you, that was very awesome, giving an overall picture.
Thank you. And yeah, that's an interesting point. So for context, some of our participants fill it out right in their provider's office. Some of them can go home and fill it out there. And that is a great point that their answers may differ depending on how comfortable they feel in each of those environments.
Thank you for your patience with me. And that was actually a great segue into my presentation, which is looking at disclosure as a possible mechanism for reducing internalized stigma. So I think I'm gonna be okay to share my screen now. Are you all able to see my screen? My slides?
Yes.
You can see my slides? Wonderful.
Yes,
Okay.
these are your slides.
So again, my name is Kristen Kasilik, and I'm an assistant professor at the University of South Florida in the Department of Mental Health Law and Policy. And I'm going to share with you briefly this morning about a federally funded research grant that I have from the National Institute on Disability, Independent Living, and Rehabilitation Research, which is looking at assessing the acceptability, feasibility, and preliminary effectiveness of an internalized stigma reduction intervention called Up to Me. So as I mentioned earlier in my introduction, I direct a research lab at USF called the Stigma Action Research Lab. If you were interested in learning more about STAR Lab, you could scan the QR code here on your screen and you would be taken to the website for our lab. I do want to share the funding statement that, this work is supported by NIDLR. However, the contents of the presentations don't necessarily represent their views. So first, I wanted to share a little bit about why the focus on college students. This chart is an infographic from the Healthy Minds Research Network, which is a center at the University of Michigan that studies college student mental health nationally. So there's a huge cohort of participants for this study. And what you're seeing on the screen is data between fall of 2018 and winter of 2021. I'm sure this isn't surprising to many of us, given we were seeing mental health challenges on the rise among the general population and college students pre-COVID, but then with COVID, we're seeing this even more so. So how does mental illness impact college students? Well, literature suggests that they experience lower GPA, that they have a greater rate of college dropout, that because of this, they have poorer economic outcomes later in life, meaning high unemployment rates and lower income. And the probability of graduating from college is 10% less for students with mental illness. And this is data from the National Comorbidities Survey. So what I based my work with Up to Me among college students, the theoretical model I'm using is Tinto's model of college student persistence. And what this model encapsulates is all of the factors that contribute to somebody entering college there on the left with these attributes that they possess pre-entry into college, including their family background, their skills and abilities, and their prior schooling. And then as you move through this model across time, there's other factors that come into play that predict outcomes, in this case, college student persistence to graduation. And one of the areas that I'm really interested in focusing is here, which is what are the experiences that they have at their institution that might predict either success or dropout. So you can see here, there's factors that are their experiences at the institution, and then also their level of integration, both academically and socially. This is work that was conducted by, among others, one of the co-investigators on my grant, which is Dr. Mark Salzer at Temple University, and he runs a NIDLR-funded center called the Temple University Collaborative on Community Inclusion. So he's looking at how people with mental illness are experiencing inclusion in their communities. And they collected a large data set of college student experiences on campus. And what they found is, if you look at the third model over here that includes all of the variables that they collected, including symptoms, campus engagement, psychosocial inclusion, some people might think that it's the symptoms of the mental illness that are leading to college students not feeling included in their campus communities. So if a college student is living with depression or anxiety, this might be, a factor in predicting their sense of inclusion. But when you look at the actual predictive weights of these variables, it's actually their relationships that are most predictive, and symptoms aren't really predicting their sense of campus inclusion to that great of an extent, at least not as huge as their relationships with other students, for example. So when I was in graduate school at the Illinois Institute of Technology, my doctoral mentor, Patrick Corrigan, and I published a paper in the American Journal of Public Health, looking at disclosure as a way to reduce self-stigma or internalized stigma. So just for a little bit of context, the program that I'm going to describe for you in a moment, Up to Me, has gone through various iterations, has been adapted for various different populations. It started out being called Coming Out Proud. Some people didn't like that name for this program, and so then the next iteration of the intervention was called Honest, Open, Proud. I selected to use the branding Up to Me, based on reviewer feedback on previous versions of my grant, which suggested that using terminology like honest, open, and proud suggested that if somebody did not disclose their mental health condition, first of all, they were being dishonest, and second of all, they should not be proud, which is certainly not the case. There's very real consequences that one needs to consider when it comes to disclosure. And so Up to Me is the branding that we chose for the college student version, which we believe suggests that this is an empowering intervention, that it is up to me whether to disclose my mental health condition. So what this paper basically laid out is that there are different approaches to disclosure, ranging from social avoidance, so not sharing your mental health challenges with anyone, in fact, actively working to conceal that experience or that identity, to broadcasting, which normally we would view somebody who actively seeks out opportunities to tell their story of their challenges with mental illness and their recovery and message of hope, that, these are advocates. And there are various benefits and costs associated with these different approaches to disclosure. And as Dr. Rana, you were suggesting earlier, these vary by setting. And so the program that we're implementing helps students to consider these different approaches to disclosure, as well as the different settings in which they might apply them. So this is just an example. These tables are from that actual article of some of the benefits and costs somebody might come up with when considering disclosure of their mental illness at work. We're having students consider costs and benefits around disclosure in an academic setting. So you can see just a couple benefits would be you don't need to worry about hiding mental illness from your supervisors or coworkers. And you can be open about, day-to-day affairs, maybe going to a counseling appointment or a psychiatrist appointment. Costs, though, are also equally important to consider. You might face disapproval if you disclose your mental illness because of the stigma associated with mental health conditions. People might gossip about you. So we also conducted a study with a large sample of college students from 5 post-secondary institutions, because we were asking, I guess it's a feasibility question, would a program like this even be of use to college students? And what we found is that 26% of our sample had been diagnosed with a mental illness. 66% reported feeling to some degree challenged by those mental health concerns. 12% strongly identified as a person with mental health challenges. 9 had significant shame with their mental illness, which I think, Lauren, is aligned with some of your findings around stigma among people living with HIV, in that they didn't endorse high levels of stigma, internalized stigma. 21.2% of the sample felt that they needed to keep their mental illness a secret, and 16.3% endorsed a desire to join a program that would help with disclosure of their identity, such as a program like Up to Me. So I'm hoping that this video will work. And if somebody could just let me know if you're unable to hear audio, that would be wonderful. Sometimes we know technology glitches a little bit. This is a video that was scripted, animated, and by students in my research lab in order to help with recruitment for our study. So it describes what the Up to Me intervention is all about.
Robbie is a college sophomore living on campus with bipolar disorder. He can sometimes experience changes in concentration and alertness in classes and feels insecure on others due to severe mood changes. Because of this, he has fallen behind in class and has had a hard time making close connections with people in his dorm. Because of the stereotypes surrounding mental illnesses and the shame that Robbie believes comes with it, he is forced to struggle in silence, dealing with the symptoms of bipolar disorder alone, instead of feeling comfortable asking for help or explaining his situation to others. After a particularly difficult day, Robbie is scrolling through social media and sees an advertisement for a program titled Up to Me. Up to Me is a 3-session group program that brings together students who experience mental health challenges and feel a sense of shame or isolation as a result. The goal of the program is to teach students 3 important lessons: to show that they hold the power over their mental illnesses and to give them the information and confidence needed to make decisions when it comes to disclosure. The program will 1, help students weigh the pros and cons of disclosing their diagnosis and struggles. 2, help students decide who it is best to disclose to. And 3, help participants craft their own disclosure story and decide how to disclose. After attending the program, Robbie decided that he felt comfortable enough telling his friend about his experience with bipolar disorder, as well as someone at the Student Accessibility Services in order to seek accommodations at school. He began to see how both can help him so that he no longer needs to face anything alone. With the help from Up to Me, he came to the conclusion that in these cases, the pros of disclosure outweigh the cons, and he felt confident in the way he was going to tell his story. The Stigma Action Research Lab, directed by Dr. Kasilik, will be evaluating the Up to Me program to determine its effectiveness for reducing feelings of shame and isolation experienced by USF students experiencing mental health challenges, and for helping students to become more engaged on their college campuses.
Okay, so that was just a little bit about the intervention. If you had any interest in actually experiencing this intervention, in order to make up for missed sessions, so you heard that it's a 3-session program and each session is 2 hours, and sometimes students aren't able to make one session. We developed some asynchronous modules. So this is actually our co-facilitator, who is a college student living with a mental health condition, and myself facilitating the intervention asynchronously. And if you scanned this QR code, it would take you to the YouTube page where you could find those videos. Quickly, I just wanted to let everyone know that there is an accumulating evidence base for the effectiveness of this program for diminishing self-stigma and other having a positive impact on other outcomes as well. And this has been studied on college students in the past. However, the outcomes that have been documented have been regarding self-stigma, appraisals of stigma as a stressor, and self-efficacy around disclosure, but not on a sense of campus inclusion. So that's really what the work that we're doing is bringing. This is the innovation, is that we're trying to document whether this intervention would actually impact post-secondary persistence. We're studying this across the course of 6 months. So the students are randomized to either receive the intervention or to a waitlist control. And then within the intervention group, they're further randomized to either receive a booster session that follows up with them a month after their initial participation, or not receive that booster. So this is just our recruitment flyer. Students who are interested scan this QR code and they're brought to an eligibility questionnaire that's administered through a survey platform called RedCap. Here you're seeing those eligibility items. You might have noted in the video that we talked about a sense of shame. When we only included this first item to assess for whether or not the person would be appropriate for the intervention, we didn't have a lot of people acknowledging shame, again, in line with what Lauren experienced with her data. When we added these other items, though, something interesting happened. In my opinion, it's interesting. So this is data from 135 people who completed the eligibility questionnaire. And as you're seeing here, far fewer people are endorsing things like shame and embarrassment, but students are feeling nervous and self-conscious about disclosure of their mental health condition, and the largest proportion are feeling judged. So when you look at the levels of stress that students are experiencing around stigma, which is measured by the scale here on the right, you see a range of scale scores from 8 to 56 on this instrument. The mean that we've collected for the baseline data, now this is only 18 people, so we'll have to see how this shapes up over time, but there is, I'd say a pretty significant level of stress around stigma. The Y Stigma scale measures loss of self-esteem or self-efficacy as a result of internalized stigma. The range here is 14 to 98. Our mean right now is 29.81. There were a few participants who didn't complete this measure, they skipped it. And then the self-stigma of mental illness scale, the range is, there's 4 subscales on this instrument. Awareness, agreement, applying the stereotypes to oneself, and then the resulting loss of self-esteem and self-efficacy. And as you can see, the range is 5 to 45. More people endorse awareness of stereotypes, which makes sense. But if you look down here, it's not an insignificant level of feeling hurt by internalized stigma. So our hope is that this intervention will help to ameliorate the effects of internalized stigma on college students. So timeline here is this was funded in September of last year. We're in the midst of data collection right now, and we will have findings to report by the end of August of 2024. So if you're interested in following up on this, I'd love to hear from you. Thank you so much.
Kristen, thank you. That was really amazing. I'm going to cheat and ask you a question as I did Lauren. I found it fascinating around shame, embarrassment, but the judge. Do you think that those things like being judged could lead to a shame? And maybe it's the word. I mean, how do you make sense of that there's such a huge gap between like a shame, but I feel judged and self-conscious about it?
Yeah. So we have a community advisory board that is all college students living with mental illness. And we actually met with them yesterday evening, and I presented these slides to them and asked for their interpretation, which I think is much more meaningful than mine. And what they said is that, they don't really, as Lauren showed with her data, they're not really endorsing high levels of stigma, but what they're really worried about is how their campus community is viewing them. Which I think still speaks to the importance of helping people to, one of the things I didn't talk about is part of the lessons of Up to Me is, some people are going to be safe disclosure partners and some people are not. And there's ways that you can test people out for that. So I think that the implication is, how do you identify people in your campus community from whom you won't expect to be judged? So I don't know if that answers your question, but yeah, I think it's really fascinating, and I'm interested in digging more into this idea of judgment versus shame.
Thank you, Lauren. I'm Kristen. Hopefully we'll have a chance to come back at the end. We have about 25 minutes left. So I'm going to move on to our next presenters, Duncan and Ellie. I want you to introduce yourself again and go for it.
Hey, thanks very much. Can you see me and hear me?
Yes, I can see you.
So I'm Duncan Short. I'm Director of Global Implementation Science at ViiV Healthcare. And Ellie, do you want to introduce yourself?
Hi, everyone. Yeah, I'm a Program Manager in our Global Positive Action team at ViiV Healthcare.
Okay, I'm just going to share the presentation.
Thanks, Duncan. Great. Hi, everyone. Thank you very much for the opportunity for Duncan and I to present this morning. I'm glad we finally made it into the session so we could present. And thank you to the other presenters as well. It's been really interesting listening to your presentations. Whilst we're working out the slides, Duncan, I can see your presenter view at the moment. rather than the.
Okay. Apologies.
Yeah.
Is that
but
better?
Whilst that happens, just like to disclose that both Duncan and I are employees of ViiV Healthcare, and also I'd like to acknowledge our study collaborators over at the University of Washington. So Lydia Drumright, Rob Fredrickson, and Heidi Crane. So today the plan is for us to be talking to you about internalized stigma, what we know and where we're headed. And it also includes presenting some early findings we have from our stage study. So you go on to the next slide, Duncan. Thank you. So over the last 40 years or so, there's been great advances made in treatment and prevention that have just dramatically altered the course of HIV. People living with HIV now have life expectancy, approaching that of the general population. They're able to live long and healthy lives. U equals U is now a fact. So undetectable equals untransmittable, and has been an absolute game changer, meaning people living with HIV adhering to their treatment and achieving an undetectable viral load cannot transmit HIV. But unfortunately, the understanding and reduction of HIV-related stigma has not kept pace with this. Next slide, please, Duncan. So despite having tools, medicines, interventions available to end the HIV epidemic, stigma remains a significant barrier to people benefiting from effective treatment, and around half of people in the US living with HIV are not virally suppressed. So although we've come a long way, there's still a huge amount to do to break down the misconceptions and educate people to change their attitudes towards HIV. It's not acceptable that stigma still has this persistent impact on the lives of people living with HIV around the world. This has been kind of recognized in the UNAIDS recent targets, but frankly, that's not quite enough. It's everybody's responsibility to think differently about stigma, and to really make it a smaller part of people's lives. Next slide. So I'll be handing over to Duncan soon to talk about some of our data and where we're headed, but we thought it was important first to kind of refresh almost the origins of stigma and where our study is focusing. So first of all, its origins. We thought this was really interesting, and it's a word originating from the ancient Greek language, and it's the practice of marking enslaved people and soldiers to identify them to whom they belonged. So that evolved into associating people with a discrediting attribute, which then caused them to be kind of tainted or discounted in society. And that has led to an association with negative stereotypes and discrimination that we see now still. So if you go on to the next slide, Duncan. So these negative attitudes and beliefs concerning people living with HIV, because of their diagnosis, are kind of split into 4 key classifications, if you like. So you can see on the slide there. But the first one is anticipated stigma, so the belief that prejudice and discrimination will be directed at you from others kind of in the future. Enacted stigma, so the experience of stigmatizing and unfair treatment from others. Intersecting stigma, so seeing this as a theme already today, but populations that are already disproportionately affected by HIV are also experiencing other types of stigma and discrimination due to their race or ethnicity, gender identity, sexual orientation, substance use, engagement in sex work, perhaps, and so on. And then finally, there's internalized stigma. So that feeling that an individual has about themselves with respect to their HIV status based on an internalization of social norms that they face in society. So for our research, we are focusing on internalized stigma, as I've already mentioned. If you go on to the next slide, Duncan. So the picture on the left here is a representation of, an example of what someone facing internalized stigma may feel and may think. And these are based on societal norms around HIV and the resulting beliefs that they have. And internalized stigma has a real impact on mental health, and healthy behaviours are also negatively affected by that. So this can take place at the individual level, family level, community level, or structural level in society, and that can really impact life opportunities for that individual. So, for example, educational, employment, relationships, and also accessing healthcare and health saving services. Next slide, please, Duncan. Great. So this, this brings us on nicely to a bit more of the research focus. So currently there is some, obviously we've seen some today, but there's a limited number of studies focusing on internalized stigma, often with quite small cohorts. To date, these studies have been suggesting that internalized stigma varies with race, age, sexual orientation, and years since HIV diagnosis. It is also associated with higher levels of depression and anxiety. It negatively impacts health-related quality of life. There's also an increased risk of poor HIV adherence and viral suppression. And it's also associated with measures of physical functioning, including risks of falls, which is a common indicator of frailty in aging populations. So that's kind of some of the studies that we've seen so far, but I'm now going to hand over to Duncan to take you through why our study is an important next step to that.
Thank you, Ellie. So as Ellie says, internalized stigma is a relatively under-researched area, and studies to date are essentially limited by a number of factors. There's a number of studies that have very small sample sizes, or most studies have very small sample sizes. There's also very limited exploration of subgroups, and research also tends to look at a single point in time. And as Lauren alluded to earlier on, there's real value in looking at multiple points in time for longitudinal data. And I think what this means, because it is under-researched, it means that our understanding of internalized stigma, our ability to confidently target interventions is quite limited. So to move to the next level, I think what we need to do is supplement the current smaller projects or more common sort of projects of certain sizes and designs that will continue to add huge value. But we need really larger studies as well to answer some of the data gaps and some of the questions that the current studies aren't answering. So like I said, it's great to see Lauren's DC cohort talking about sample sizes that are not just starting quite large, but are also planning to go in the longer term as well. So one example of the sort of studies that we're thinking is the future direction in many ways is the STAGE study. And the STAGE study is a project that Ellie and I work on with our collaborators at the University of Washington in Seattle. And what makes STAGE and studies like it different is the volume of the data. So it's the sample size, but it's also the range of data that the measures of stigma we can actually link to. So now I'll come on to that in a second. But potentially STAGE is one of the largest ever, if not the largest ever, study of internalized stigma. So we have over 11,000 patients now. It started with just less than 11,000, but it's a live cohort that continues to grow as we build our analysis. And we have over 21,000 different unique assessments and data points. So that's what makes it quite a special design. And the end of STAGE really is to explore internalized stigma and its associations in granular detail. So we'll look at things like the total cohort and the aggregated data, but we'll also look at, because we have such a big sample, we can really drill down into some of these subgroups to see whether there's differences in things like gender and ethnicity and geography and age, for example. And we can also look at other very under-researched areas, such as health outcomes, such as mental health, or we can look at substance use, viral load, adherence, and other age-related outcomes. So that's what we're planning to do with the STAGE study. Just to give you an idea about where we're coming from with this data source is called the CNIX network, or it's from the CNIX network, which is the CFAR network of integrated clinical systems. And that's a measure of it's taken from 8 different clinical sites across the US. And in these sites, what happens is patients, as part of their routine care, complete questionnaires which provide us with all of these insights. And because this has been going for such a long time, that's how we've managed to build a data set of over 21,000 different data points from over 11,000 patients. And these questionnaires also link to other data sets which enable our analysis to be much more significant. So it links to things as you can see on the screen, things like demographics and diagnoses and lab results and healthcare utilization. So the potential for a resource like this is really significant in terms of its volume and its breadth of data. Now, I just wanted to reiterate the measure that Lauren actually mentioned as well, because that's the same measure that we use within CNIX. And before we look at it, I think it's really important that we just pause and make sure that we really understand what it is so that we can interpret the data more effectively. So this is a validated scale. It's academically robust and it's very well published and respected. But to understand it, you've really got to look at the language. So if you read the 4 questions on the left-hand side, they're very emotive, and they do make me feel slightly uncomfortable when I think about somebody potentially vulnerable answering them. But I understand why it's designed, how it's set up. But essentially, anyone responding, 1, strongly disagree to any of the 4 questions is saying, I don't have internalized stigma. That's essentially the message that is coming through. Any response greater than 1 to any of the questions indicates some degree of stigma. And I think it's important to highlight that for when we show our results, and they compare quite favorably with what Lauren, or quite consistently with what Lauren showed as well. So this was our cohort of 12,000 patients. And what you can see from this one is the mean response to every question hovers round about the 2 mark. So remember, anything greater than 1 indicates some degree of stigma. So it's quite telling that the average is round about 2. And then when we actually look at the distribution of that, you can see there's a significant amount strongly disagreeing, indicating no stigma, but there's also a significant amount to the right, certainly moving across into the 3, 4s, and 5s, that actually show that there's a real worrying amount here of stigma, and it shows the scale of what that problem actually is. Just to reframe in a slightly different way as well, this is the same data, but essentially it's just reframing it in a slightly different format. What this is telling us is that 64% of the 12,000 respondents indicated some degree of internalized stigma, and 39% averaged greater than 2 across the 4 questions. So bear in mind, 1 is the extreme that we're looking for. So 39% averaged greater than 2, and 47%, or almost half, responded to at least 1 question with a 3, 4, or 5. So it's really powerful, and we can start to really advocate for the importance and the impact of internalized stigma as this project progresses. Now, I've mentioned already that one of the advantages of the CNIX cohort is the volume that we have, having a growing number, which is already beyond 12,000. And one of the things I can say about this is when we look at the aggregate level, for example, if you look at the top 4 data points here, what this shows you is that compared to those under 30, internalized stigma reduces as people age. That's essentially the message of what it's saying. And similarly, the second set of data, points 5 to 8, what that tells you is that those who've been in care for less than 1 year, internalized stigma reduces the longer you've been in care. So that's the total cohort. But just to show the value of being able to drill down, and this is analysis which we've just been starting really, but when we drill down, if we just look, for example, at those conclusions by splitting it by race, stigma, remember the first message was that stigma levels reduce as people age, and that holds in this case for the people who are Black, but the people who are white, that doesn't hold. So there's something very different going on here. And it shows the real value of being able to drill down, and we'll continue to drill down and ask more questions here. The second data point about care, again, the finding that compared to those who've been in care for less than 1 year, stigma reduces the longer you've been in care. Again, that holds for the white group, but it doesn't hold for the Black group. So again, it's another example how we can't necessarily take things on the overall assumption. We need these large data sets to be able to really drill in, because only by drilling in can we then really start to understand stigma and start to target interventions to subgroups which really matter. Just to give you some example of some of the other early data that we're starting to look at, we're also looking at HIV transmission modes, and what you can see from the second column here is that stigma is high across all of the transmission modes that we were able to measure. However, in the mother to baby transmission during the perinatal period, you can see again that is very high. So again, that begs a lot of questions about different groups and different levels of stigma. And certainly working with one of the pediatricians I work with, you know, we've got a plan in terms of progressing that analysis as well. Another part of our early exploratory analysis was looking at ART adherence. And what you can see here is that those experiencing stigma are less likely to be adherent to their ART medicine. And essentially having internalized stigma is attributed to a reduction of over 5% when you're looking at the range of scores. And to put that in context, when we think about amphetamine use, for example, methamphetamine use, that's widely acknowledged as a very damaging factor in terms of adherence, yet that's reported to be around about a 4.6% effect. So you can start to see again, internalized stigma, a very significant thing that we need to start addressing appropriately. And then finally, just in terms of our early data, we've also been looking at quality of life as well. Now, this isn't the same study. This isn't staged. This is a different study that I manage. But again, this has made a very strong association in a very large sample as well between internalized stigma and quality of life. So again, it's showing what a significant problem internalized stigma is, and it should be resourced, addressed, and prioritized accordingly. So to conclude, you know, what must we do about stigma? Not just internalized stigma, stigma generally. Data is one thing. I've been talking about data today, but actually, yes, data is very, very important, and we need to develop studies and answer the questions and address the data gaps that we need to. But we're certainly not advocating that's the only answer. And I think one of the exciting things about this conference is I think we're going to hear, for example, how we can address different kinds of stigma, because unless we do address stigma, we certainly can't end the epidemic. I think we're also going to hear about different interventions and strategies that can be employed to make a difference. This is going to include things like involving people in service design, including stigma reduction in policies, protecting people through various legal channels, and helping people to understand their rights and to act upon violations of these. And importantly, educating to challenge and change attitudes. So I think what we're going to hear, hopefully, over the next few days is a lot of different strategies and impact. But I think the message that stigma is incredibly important and needs to be resourced and addressed appropriately, I think that's going to come through loud and clear. So I just want to end there and just say thank you on behalf of Ellie and myself for the opportunity to present at the conference, and thank you for listening.
Can I say something very quickly? Thank you so much for these outstanding presentations, every single one of you. I mean, I truly, thoroughly enjoyed them and learned so much. I just want to say one thing for HIV data. I think it's very important, but data comes from those patients who are linked to care already, number one, and they are retained in care. And number three, they feel comfortable enough to talk about something very private to them. You know, even confessing to somebody I'm ashamed, man, it takes me a long. So people who are not linked to care, people who've not been tested and are scared to get tested because what people would think of them if they're getting tested, people who got diagnosed but are not going for care or not retained or don't come very often or refuse to fill these surveys are not included. So very, very wonderful presentation, totally awesome. But you know, I'm aware of so many people who have HIV who don't come for care. They call me for a lunch ticket or this or that, but they would not come to see us for prescription. And they are very, very broken. And I think we have to devise some strategies to find a way to survey those people, some instrument, why and how much stigma is there and whether it's stigma or other things that are impacting their inability to link care. I want to tell a very short story. One time, one of our graduate students was crying in my office, and I asked her, what's wrong? She said, my grandma won't go to emergency room. She's having chest pain. She's had 3 heart attacks and now she's having chest pain, but she won't go. And I keep begging her and she says, no, I don't. And I said, Grandma, why don't you want to go? She said, they're going to ask me again how many cigarettes I smoke. And that blame alone was keeping her away from seeking care because of her experience, but also anticipated. Yeah. Thank you so much again. This was awesome. Every single one of you.
We have one panelist left. Duncan and Ellie, thank you very much for that. We have one panelist left, that is Terrell.
Oh, there is Terrell.
Yes. And I'm going to put this out there for Duncan and Elle. Hopefully we have time for it. I'm wondering if some of these questions are impacted by resiliency, like people can respond, but they're responding from a space of power and resilience. So we'll put that out there just as a question, but we're going to hear from Terrell Parker. Terrell, take it away.
Yes, hey everyone. I am not exactly certain how much time I have. Ken, how much time do I have?
Just keep talking until it fades away.
All right.
I'm sure we can go a little over, but keep just go ahead.
Terrell, we want to hear you.
Yes, absolutely.
All of it. You guys have put so much work into this. So we want to hear you. Thank you for being here.
Thank you. So I am here representing NMAC and the Escalate program, as I mentioned earlier, which stands for Ending Stigma Through Collaboration and Lifting All to Empowerment. And of course, we cannot do this work without the support of our funders at the HRSA HHS HIV/AIDS Bureau. So when we think about Escalate, I always start with why is Escalate important? NMAC created Escalate to reflect its mission statement. If you're familiar with NMAC, our mission statement is NMAC leads with race to urgently fight for health equity and racial justice to end the HIV epidemic in the United States. That simply means that we understand that while HIV is an intersectional issue, it impacts people of color, Black, Indigenous people of color, most disproportionately when we look at new HIV acquisitions and when we look at health outcomes across the HIV care continuum. So we know that from an intersectional perspective, if we're going to talk about ending the HIV epidemic and talk about ending stigma in the United States, we have to talk about race as a driving factor. So specifically, what do we hope to accomplish with Escalate? It was really interesting hearing so many of the presentations that came before my presentation, because you all talked about exactly what our goal is with Escalate, and it's really to reduce stigma at every level, because we do see how stigma impacts people at an individual level. So the stigma that people living with HIV experience and face, stigma within our clinics and organizations, and also within our systems. So within our healthcare systems, but also within the broader community, which is something that I've heard discussed consistently throughout today's plenary session. So how do we do that? We do that by providing a supportive training space where we focus on implementing various stigma reduction interventions. And each intervention has a strong emphasis on cultural humility. So I'll share just briefly why cultural humility is a tool and a resource for us. And then more importantly, share some of the data that we're finding from Escalate in our first year or so of participation. So we have 3 tracks that we have created from Escalate, which is our stigma reduction training, our targeted time limited TA, which organizations can participate in over 9 months and receive an individual TA coach to help you develop a stigma reduction plan and to measure and assess your goals towards implementing that plan. And then finally, a learning collaborative. So it was amazing hearing some of the great work from folks like Lauren and Kristen and also Dr. Reyna, because you all would really be prime candidates for our learning collaborative. You know, folks who have done some stigma reduction work in your local communities, your local organizations, and you want to have a space similar to this where you can learn from other organizations that are doing this work, learn best practices. As my colleague likes to say, training helps you to see the mountain. It helps you to see the challenges, to understand what stigma is. TA helps you to learn how to climb the mountain and get the assistance that you need. And then the learning collaborative is working with great folks like we've talked to today that have been doing this work that can help us get to the top of the mountain and learn the best practices for doing this work as we continue to utilize stigma reduction as a method to eliminate the HIV epidemic in the United States. So I always like to highlight that from the very beginning, the conception of Escalate, we brought these communities to the table. As I mentioned, our mission statement is NMAC leads with race, and we also understand that HIV is an intersectional issue. So we brought over 65 subject matter experts from these impacted communities to the table from the very beginning, all the way from the curriculum design to our facilitation team, to our marketing and communications team, to ensure that not only did we create a program that really met the needs of the community, but a program that reached the communities that we were trying to serve. And those are the communities that are most disproportionately impacted by HIV-related stigma. So this is a preview for what you would experience if you were to go through an Escalate training. What people say about the Escalate training is that it's robust, it's challenging, it goes there, and it's unlike any training experience that you will ever take. I like to say that. Maybe I'm a little biased. But for the first 2 days, how I like to describe it is it's really laying the foundation. We go through the very basics of stigma, HIV-related stigma, and how it specifically impacts the healthcare. And once again, since we lead with race, we do talk about race as a social construct, how it impacts the work we do, and then how we can begin to create changes within our work. I'm going to share some slides about cultural humility really quickly. And then finally, the bulk of my presentation will talk about really day 4 and day 5. So day 1 and 2, we learn the foundation. Day 3 and 4 is all about application. As we see stigma, as we recognize privilege, how do we leverage privilege? How do we recognize intersectionality? How do we disrupt these things when we see them taking place in our work environments and within the community? And then on the 5th and final day, it's all about assessment. So we have a really great assessment tool that I'll share with everyone. And it's all about how do we take the knowledge that we've learned in the training and then apply it back within our local communities. So why is stigma and cultural humility really important? We talk extensively about cultural humility, how it shapes and informs the work that we do, and how it can be used as a tool to reduce stigma in our work. So these are the 3 main components of cultural humility that we like to share with our participants in Escalate. And I always like to highlight this first one because this is really what I like to say is the meat and potatoes of participating in an Escalate training. We ask folks to do a great deal of critical self-reflection. What is your work environment? What does your community do? How does your community or your work environment either perpetuate or dismantle stigma? And how do we use cultural humility, taking that approach once again to reduce stigma? We also talk about culture very specifically, and we talk about how culture looks different. Culture looks different in community, culture looks different in the home, culture looks different in your clinic, culture looks different within your community-based organization. Although culture looks different in each environment has a unique role in impacting healthcare. I often share what it was like living in the home with a parent who was a diabetic and how I had to learn how to measure insulin, how to take my mom's blood glucose level. So for us, healthcare definitely extended well beyond just her doctor's visit, where she may go to quarterly and see her doctor for 15 to 30 minutes. So we talk about what does it look like when the healthcare of culture and community bumps up or clashes against the healthcare of our community-based organizations, our federally qualified health centers, and our health departments. And then how does culture manifest? And then what does that manifestation of culture lead to? How does it lead to very real HIV-related stigma within our healthcare facilities? Because once again, we're talking about critical self-reflection, because we want to make sure that we do reduce stigma within an individual level. But what as folks have spoken about, we see stigma being perpetuated within a systemic level as well. So at the heart of Escalate, we're constantly saying, what can we do to break down and dismantle the systems that perpetuate stigma? And unfortunately, as we've heard, sometimes our healthcare systems do perpetuate that stigma. So what does stigma look like in our healthcare facilities? It looks like refusing to provide treatment, gossip or verbal abuse, something that we've heard today, differential treatment. I know we've often talked about HIV stigma, but I love the cross exchange of ideas. I've heard from so many folks that this information is relevant across many different disease states, not just necessarily HIV. When I look at this bullet and talk about differential treatment, I share the story of when I was on the plane ride home from an Escalate training, and I sat next to someone and we were sharing about the work that we do. And she said that she works in lung cancer. I said that I'm doing a stigma training. And she said, interesting, because she was just at a lung cancer training and they were talking about stigma and how lung cancer is stigmatized, and how she sees how folks, if they come in for a treatment for lung cancer, how long they have to wait in the waiting room versus other forms of cancer, the treatment that they receive from their medical providers versus other forms of cancer. Because with lung cancer, it's often that person deserves it, they're otherized, the assumption is that they were a smoker, so they did something to deserve that form of cancer. So that's stigmatizing. So many of these things, although we have these discussions and we talk about HIV, we can probably substitute HIV and they would be applicable across many different diseases. And of course, what is the impact of stigma? We've talked about it so much, but one of the common challenges that folks often face in doing this work and sustaining the work is understanding the importance, getting the buy-in from leadership. Often we hear we're not funded to do stigma work. It's not my responsibility to manage a stigma project. I'm doing this as an other duty assigned, as we often hear. But I love to share this graphic with folks. I always love to tell folks to take a picture, because this really embodies why it's important for us to do this work. We look at the things that are predictors of HIV-related stigma, whether it's enacted, stigma you feel, stigma that comes from your community, as we've heard, anticipated stigma, just stigma that I anticipate by walking into a place or living in a certain identity, and also that internalized stigma, the stigma that we've heard about so much today. How does it impact us? It leads to mental stressors, mental health, psychological resources. It leads to challenges that we found, and those psychological challenges have a very real implication on engagement in care and ultimately HIV-related health outcomes. So I love to share this slide, but also the larger article, because it goes into much greater detail in understanding this concept. But there are real implications to stigma, the work that we do, and ultimately our bottom line, which is to keep people engaged in care, to keep them healthy, and ultimately help them to reach viral suppression. So if we don't talk about stigma, there will always be those gaps in making sure that we help people reach optimum health outcomes. So I don't love to share this story, but I share this story because it really drives home the message from the previous slide. And someone else shared another personal story, but this is a story of someone I knew who was 28, who had been living with HIV for almost 10 years, who had various degrees of accessing care for many reasons, but mainly due to fear. They had not been successfully retained in care for a few years. They became physically ill, so they started accessing care. One day they walked into their provider's office for a doctor's appointment. They saw a friend that they knew, and then they walked out of the doctor's appointment out of fear, being recognized, that anticipated stigma that we talk about. So within 6 months, unfortunately, Sean developed a form of cancer related to his HIV. And due to a weakened immune system, he died shortly thereafter due to complications of the cancer and his weakened immune system. And I shared this story because this happened to someone I knew in 2014. And I was the friend who was waiting in the waiting room. When I first started working in Lincolnshire Care, I would take clients to their medical appointments. And during my first month working in Lincolnshire Care, I saw a friend that I know who walked into the clinic and later walked out because he was afraid that he would see me. He didn't know why I was there. He assumed that perhaps I might disclose his status to someone else. You know, all of the stigma that exists within community, all that internalized stigma, all that anticipated stigma. So I share that story to say that that wasn't that long ago. And unfortunately, while we do hear many of the success stories of those who do reach viral suppression, there are still those who avoid care and avoid receiving the services that they need because of the very real stigma that exists within the community, and also the anticipated and individualized stigma that many folks have shared about today. So also, I believe it was Dr. I can't recall, in the beginning talked about stigma and how we weren't able to really find a lot of research on stigma, but in doing some research on an unrelated topic, I found this article and it was really profound to me because it was from December 2nd, 1985. It said, "We risk the creation of a class of pariahs, people so stigmatized by their association with the disease that they can't keep a job or a home or buy insurance," said Thomas B. Stoddard, a lawyer with the American Civil Liberties Union. And this was an article specifically related to the rise of HIV and stigma. And I thought it was very profound that even in 1985, over 40 years ago, that this was a discussion, and someone kind of warned us that if we were not cognizant of how we treated people living with HIV, the risk that we ran of stigmatizing that group of people. So really quickly, I'll share some of the data from our training that we have from our first round of Escalate. So we have currently trained 249 individuals. Since then, the number has increased. We're reaching approximately 350 individuals trained. 40 individuals have gone through our technical assistance, and 38 individuals have gone through our learning collaborative. That includes 28 different states, including DC, 50 different Ryan White funded organization parts A, B, C, and D have gone through the training as well. So we have, in our evaluation of our training, we have seen a significant increase from our pre and post, those who have identified an increase of either their knowledge, their skill, or their behavior for addressing and identifying and reducing stigma as a result and participating in the Escalate training. And this also just describes how what folks' expectations were coming into the training and what they received. So overall, across the board, folks strongly agreed that Escalate met their expectations for the training, that the training action plans seemed realistic and doable, because at the end of the third day, after completing an assessment, each organization does complete an action plan that they are then charged with taking back to their community, to their organization, and implementing. So they found that their action plan seemed doable, which we found really critical because we wanted to make sure that the goals that they set for their organizations were attainable and that they could do it in light of all the other work and competing priorities that they may have within their organizations. And we found most interesting that within talking about the support that organization received in doing this work, most respondents found that their colleagues support addressing doing this work for HIV-related stigma, even more than their supervisors. They found that their colleagues and their peers were more likely to support doing this work. But if you also look, one of the lower bars is I already know what opportunities there are to use this training in my work. So while participants have found this information useful and they're eager to go back to their communities to do this work, they haven't necessarily found that there were opportunities that were pre-existing, maybe before Escalate, where they can just jump on board, take the knowledge. So we found that maybe the platform or the foundation to do the work has not existed previously in some places. Some of the organizations that we've seen today, I would say, are probably really far more advanced in doing their stigma reduction work than many of the organizations that we've worked with that are really at the foundational level of beginning to do this work. And then also, one thing we found is that most organizations, while they may have some policies in place, most organizations do not have policies specifically related to stigma. And we found all of this data through our Escalate organizational self-assessment, which is a 4-part self-assessment tool. Each stigma reduction team that participates in Escalate, every team member has to complete the assessment. And we use this baseline assessment across every track of Escalate. So whether you participate in training, TA, or the Learning Collaborative, you complete this. And it's really to identify any gaps within your organization and to identify action steps for reducing stigma within your organization or within your community. So once again, I'll share the slides with everyone in the interest of time. I won't go really deep into all this information. I'll just share some of the things that I found related to the previous slide. As I just mentioned, most organizations have policies in place. They have formal policies for confidentiality. They have complaint processes. They have some organizations have addressed or at least stated that they have a commitment to addressing stigma. But when we go further down and when we talk about specific policies that are in place that not only are in place, but staff members are aware of them and they're being used, that is where we see a drop. So when we talk about it, reducing stigma from an organizational perspective, we start to focus on how can organizations look at policies and procedures specifically that address stigma as a way to reduce stigma within your organization that your clients or your patients may face. And then also just something that I also wanted to highlight, when we look at taking a trauma-informed approach to work. So let me take a back up 1 second. When I talked about the 4 areas that Escalate highlights, the first area that Escalate highlights is policies and procedures. And those are the things that we look at. The second area that we look at is staff competencies and support. So one thing that stands out to me on this graphic is just really the need to maybe invest more in trauma-informed approaches to our work. Overwhelmingly, participants stated that either trauma-informed approaches do not work, or some people in the organization are aware of the issue, but there is no real work policy being done to really implement trauma-informed approaches to the work. Once again, when we talk about supervisor support, most of the support is somewhat there for observing and reducing stigma, but I would say 50%, only 50% of folks said that they had a lot of support from their supervisors in doing this work. When we looked at client and community engagement specifically, and this is important, when we look at reducing stigma on a community level, when we look at things that exist, when we look at graphic materials that exist, some folks said, yes, we have a sufficient way to deal with our organization, which is great, but more often than not, folks said no, but they either recognize the issue or yes, but more needs to be done. When we look at consumer feedback, even more work, folks say that they recognize it, but more work needs to be done, or that yes, but there is more work that needs to be done. When we talk about recruitment, even more work needs to be done, to recruit people from community, to participate in community engagement, marketing campaigns, things of that nature. And most overwhelmingly, where we need to do work when we talk about clients and community engagement is around cultural humility and feedback. Overwhelmingly, folks said either no or no, but some people in the organization are aware of it, meaning that no work has started or no work is being done to incorporate cultural humility in our feedback and in our work that we do. So we are going to continue to implement Escalate. Escalate is a 4-year project. We are going until 2024. I'll tell you very shortly how you can engage with Escalate. There are also other opportunities for you to participate, whether in person, virtually, in blended formats. We also have opportunities for organizations to work with our evaluations team, and we can work with your entire organization to do a facilitated EOSA, which is an organizational assessment of how your organization is addressing stigma within your organization and within the broader community. So I'll close with saying, how can you engage with Escalate? Escalate currently is for organizations that receive Ryan White's Parts A through D, and those are both recipients or subrecipients. Maybe you're a recipient from the county or the city or the state. Health departments, community-based organizations, FQHCs, planning councils, planning bodies. Anyone who receives Part A through D funding is eligible to put together a stigma reduction team. You can attend a national training, send 3 to 6 people. You must put together a stigma reduction team. One thing that's important, your stigma reduction team must include a person living with HIV, along with representatives from your Ryan White Blended organization. You can access our application and also learn about being engaged with our technical assistance program and our learning collaboratives at targethiv.org/escalate. And thank you all for your time. Thank you for staying over. I greatly appreciate it.
Thank you, Terrell. That was a great presentation. I think it was a great sort of ending to what we've learned, and then ending with like, what are the things that we can do? Thank you to all of our panelists. Amazing presentations. This is stuff that we will continue to talk about throughout the conference. Because we're over time, I do want to turn it over to Patty for an announcement. But again, I just want to say thank you to our panelists. Amazing job. Virtual hand clap, if you have one out there, I think was amazing. Patty, I'm going to turn it over to you.
Hi, everyone. My camera's working now. All I wanted to say is don't leave this session yet, because we are about to play a couple of our stigma stories that we've collected. So they're going to play right in this session. So stay in here, and then that'll just be a couple minutes. And then when you log off here, go back out and you can log into our scientific abstract session, and we'll see you there. Thank you.
Had hereditary hiatal suicide attempt. I lost all form of hope of surviving this disease because of how badly I was stigmatized. I hated who I was. I became extremely ashamed of myself. I lost my confidence, my self-esteem, and became depressed. I hated going to hospital because I don't want to be called a stigma. However, because of my experience on stigma, I choose to become a sickle cell advocate, creating awareness and educating people about sickle cell disease. I don't want anyone living with sickle cell to be stigmatized just like I did. I believe stigma thrives in ignorance, and education plays a vital role in reducing stigma. Thank you.
Brian C. Jones from Cleveland, Ohio. We've got to show that peer-led models, people living with HIV helping each other, is the best model, because it not only helps each other with our internal stigma, it also helps with how we are viewed to the public at large. It's important that people living with HIV are seen not just people who need help, but as people who can help very much. And the only way we can achieve this is by allowing people or putting people living with HIV in positions of power as it relates to education and trainings, allowing those education and trainings to be implemented, presented by those people living with HIV. we have knowledge to share, and we also need to be seen as people who can very much help.
Stigma has encouraged and motivated me to share my story and be more open. I recently shared my story on Instagram after many years of being silent. And the reason being is because I had been sharing my story with so many people that I wanted to be the person responsible for my narrative. I had noticed that individuals who had been recently diagnosed with HIV often took on the stigma of the world, the negative thoughts about it, you know, how you got it, things like that. And it became heavy and most difficult to accept. It also became difficult for individuals to seek treatment because they wanted to be disassociated with it. But I would speak to them and talk to them and share my story and my journey, just as an encouragement to overlook the stigma and the doubt.
Okay, that was the end for now. We do have another set of stories right before lunch in about an hour. So everybody can head over to the other scientific abstract session now. Thank you.